Good afternoon. I'm Michelle Windale. I'm a fellow in female and functional urology at the Bristol Urological Institute, and I thank you for the opportunity to present our data on female stress incontinence surgery. The background or the setting is the increasing attention for mesh and tape complications that made us look at these data. There is the Food and Drug Administration warnings in 2008 and 2011, and then the upgrade to a Class 3 procedure from Class 2 more recently. And then the Medicines and Health Products Regulatory Agency of the UK also recognized problems with mesh and tape. There's obviously specialty meetings like these where it is more and more discussed. There's reports, expert opinions, etc. On the other hand, there is extensive litigation going on with huge claims, and that has probably led to the media attention that's currently going on with documentaries, newspaper articles, etc. So in that light, we wanted to have a look on the trend in patients' preference for female stress incontinence surgery. We did a retrospective study over a 5-year period in our single center and looked at the data of one urologist, 2 urogynecologists. And we looked at women with bothersome stress incontinence despite first-line treatment, so conservative treatment, who actually want surgical treatment because there's always the option of not doing surgery. These women get urodynamics, including a urethral pressure profile, and then they are discussed at the multidisciplinary team discussion. All surgical options are offered as per the National Institute of Clinical Excellence guidelines, so bulking agents, synthetic sling, corpal suspension, and autologous sling. And the patients receive international and national leaflets, and they get sufficient time and space to look through these, read up on these, look on the internet, discuss, think, and eventually, if they want, they can come and discuss with us, and eventually it's their choice on what surgery they want. In the past 5 years, there have been close to 600 interventions, and the trend, I don't know if the numbers are clear, but in 2012 there was about 90% synthetic sling, which declined to 65%. It's the blue ribbon in 2016. Bulking agent autologous sling remained more or less stable, but corpal suspension gained in popularity. So that titan is indeed rising again. It's 20% 2016, and we're excited to look at our 2017 data because we think the trend is continuing. So there is a change in patient preference, and it is statistically significant in these data, and therefore we think that the social attention, awareness of synthetic and tape-related complications may influence our daily practice in dealing with female stress incontinence.
Thank you. Can you go back to the slide, your first slide of the results? When I was reading your abstract, the overall decline, if you look at the x-axis, the overall decline over the years had actually, according to the y-axis, gone down overall for all surgeries. So I appreciate that you're depicting here easily on the bar graph for us to interpret that the mesh had declined. Yeah. But what is the reason for the overall decline in the surgeries over the past several years?
Well, I think patients may be more conscious about their choice and may actually opt to not have treatment because even though this trend is there, it's not, the sling took over from the older ones for a reason, because they had their appeal. Now that appeal has shown another side of itself. So maybe patients think there is no victory to be achieved and think that maybe getting surgery may be worse than actually not doing anything.
Yeah. No, and we're seeing that a lot too with the prostatectomy population too. The patients have been so frightened by their own personal complication that sometimes they don't even go for care anymore because they're afraid, and this is media.
Do you have a question there?
Hi, I'm Holly Bakama, I'm from Glasgow. Do you use shared decision-making forms for recording your patient choice for operations?
No, we like to have, we offer them all the information, but the decision is theirs.
So you
they
don't
decide.
You don't make them sign a contract with you or anything?
Sorry?
You don't make them sign a contract or in like with you?
It's coming.
That's fine.
They will sign, obviously.
We get them signed.
Okay.
Okay.
Do we still have time for a question. Can I make a question? This interesting shift with the re-increase in culpal suspensions, I assume in most cases it's mini-invasive surgery. Did it cause any problem within your center in terms of training for surgeons? Because that's a much more difficult, I think, procedure to be learned as compared to mid-urethral slings.
And you talk about the laparoscopy or open or both?
The culpal suspension term.
Yeah, so Mr. Madhu is specifically trained now, and that probably increases the appeal of this procedure as well because of the minimal invasive nature and takes away some of the downsides of the open approach. Yeah.
Question now?
Well, Gore, Scotland. This is a really interesting study because it suggests that there is perhaps a reversal of the trend that we saw around the turn of the century, of the decline of colpo suspension and the rest of non-mesh procedures and the increase on the mesh tape procedures. If a reversal of the trend is going on just now, this could be due to many factors. One of them is an anxiety about the mesh complications in the media. So how could we, or how could you design another study that unpack these factors, unpack an anxiety about mesh procedures, and find out whether it is actually is it really when patients are offered both procedures equally with unbiased information, will they go for the non-mesh option even though they don't have this anxiety? Do you see what I mean?
Yeah, I think it's difficult to design a study for that. I think time will tell because media attention, as with everything, will settle. And now patients consider mesh as probably something very, very bad and unanimously bad, but they're less aware of the downsides of the other procedures. So they gain favor now, but when the whole mesh story is fading out, I think it will probably increase a bit again and then find a sort of a balance. But how to study it, it's difficult because you can't lock patients away from everything that's appearing in newspapers and on the news. So it's very difficult to unbias them.
This is very risky. Thank you so much for your presentation and staying on time. Thank you.